Hi, this is Dr. John Alchemy with Rate Fast. Welcome back. And today I'm going to be talking about big themes in impairment rating histories and diagnostic tests. As you know, impairment reports in California are required when the patient reaches what's called maximal medical improvement. At that time, the doctor or the primary treating physician of record needs to generate a report that's basically a snapshot of the recovery and outline to the stakeholders how the individual's doing, do a history, a physical exam, incorporate the diagnostic tests, and create something called the impairment report or the permanent and stationary report, also known as the PR4 report. So in the series of videos, what we're trying to do is to improve impairment rating competency for people who have to both perform the physical exams and those who have to consume the reports. And that's the insurance companies, attorneys, judges, the DEU, and of course the patients as well. They have to have some type of reasoning in these reports as to why and how they were provided the whole person impairment. Remember, an impairment report scores something called a whole person impairment value, and that number is between 0 and 100, and 0 is where there's absolutely no deficit, either on physical exam or functional deficit, meaning everything can be done that the patient needs at home without any interruption. So what we wanted to focus on today was the concept of the history. And the histories, if you've read a lot of impairment reports or read any impairment reports, they can vary in quality and detail. The trick with doing an impairment report using the AMA guides is that the AMA guides uses very specific details in the history, and some of them are subtle, some of them are more overt. So for example, we always want to know what the pain value is. And often patients have a range of pain value. So it's always helpful for a pain score. Remember, 0 is no pain, 10 is intolerable pain. And that range can be difficult to tease out from a patient sometimes, and also for the stakeholders or the readers to understand exactly what a 5 out of 10 pain means. So the big theme in the history is this patient having a lot of pain and problems? Are they having a lot of difficulties with their activities of daily living? Because activities of daily living are really what the AMA guides are after. We can use and do use pain scores between 0 and 10 as a proxy to describe ADL function. So for instance, an ADL value of 3 out of 10 is a mild pain, and that means the individual can do all their activities but have some annoyance. When the pain hits 5, that means that the individual starts to have difficulty and the ADLs actually start to break down. They can't stand unlimited. They can only sit for 20 minutes, can lift only up to 15 pounds, these sorts of things. And these are the big themes that we want to look for in history. So we want to know the pain score, we want to know how it affects the ADLs, and we want to know specifically which of these ADLs or activities of daily living are definitely impacted by the pain scores that are being provided. When we're dealing with things such as spine, we need to know if the symptoms are radiating, if it's traveling, if it's something known as radiculopathy, which means the nerve root is having a problem and sending messages out into the extremity that the patient perceives as pain or tingling or sensory changes. That is extremely important in any case that you're looking at or reviewing that involves cervical, thoracic, or lumbar spine. And particularly when talking about the radiculopathy or that traveling pain, we need to know what side it's on, and we need to know what distribution it's radiating to. Is it radiating out to the thumb and index finger in a neck case? That's C6. Is it radiating to the ring and small finger? That's C8. And so we need to know anatomically where this pain is going, because all this is doing is it's setting up the impairment rating and giving it a foundation and a basis to make it credible and a report that is consistent, so it can be rated and appreciated by all the stakeholders that need to understand and process this report. So we want to talk about the function. We want to talk about radiating pain. We want to make sure that the ADLs are relevant. Usually if someone has pain, they're going to have problems sleeping. if it's waking them up at night. Again, pain that's 5 to 7 out of 10 should be causing some problems with sleep. It should be interfering with what we would expect to be the ADLs with the body part. So if I'm talking about a shoulder injury, perhaps, I'm going to specifically emphasize self-care, doing my hair, anything where I have to reach, dressing, tucking in my shirt in the back, putting on a jacket, cooking, lifting something with arm extended. Does that cause any pain? A gallon of milk, right around 10 pounds. Carrying groceries, 10 pounds there. So all of these activities of daily living that should be appropriate for a body part should at least be mentioned in some way in the report. And then, of course, like I said, we have the common ones that are like sleep, traveling in a car. Most everyone has to do that, and finding out how their pain and symptoms affect that. And so what we're looking for in these broad overviews of the report is we're trying to get a flavor of the ADL impact. When I interview patients, I try to ask the question from a couple of angles. Number one, what's your pain score? And then I obviously give them a range. 10 means you can't do anything at all. 0 means you have no pain. So I try to see how they're going to answer that pain score, 0 to 10. Then I ask it another way. I say, so as you go through the day, maybe it's the weekend, maybe you're not at work, but if, at home during the day, do you have a problem with a few, many, most, or all of the activities that involve your shoulder? And usually when you give people that kind of question, they can readily place their functional activity in one of those categories. Oh, well, it's only a few things. I can get through the day quite fine. Or I have trouble with most things and have to get help from my kids in order to bring in the groceries or to make the bed or to do laundry, et cetera, et cetera. And what we're really looking for is to make sure that that pain score they've given us is consistent with the activities of daily living limitation. And patients aren't really great, nor should they be, at rattling off all the 34 ADLs on page 4 of the AMA guides. We don't expect them to do that. But we do need to be asking questions in context about how the pain's affecting their day and how frequently it's affecting them and what activities. So as I said, cervical spine, lumbar spine, common areas for talking about radiating pain. So it's just very important that we have the ratable factors into the history, because that's the only place we're going to get it. Sometimes we can find it in a diagnostic test, but not always. And of course, no tests are 100%. And the second thing I wanted to talk about was the diagnostic test. So if we're doing an impairment report on a low back, I would expect that we, at a minimum, have an X-ray. I would expect, if it's been a prolonged case, that we have an MRI. I would expect that if we have a lot of radiating symptoms, maybe the individual's had some epidurals where they're injecting near the nerve roots to settle down the pain. I would expect some nerve studies. So what you want to look for as you're reading these reports, hey, this pain is moderate. It's been around a long time. The case is 2 years old. I'm expecting, as I move down that page, to see some diagnostic tests. Now, remember, in the AMA guides, the diagnostic tests play 2 roles. One is to aid with the diagnosis, and then the other is to help place them into categories for impairment rating. So for instance, maybe the X-ray shows moderate degenerative changes, or maybe there's some spondylolisthesis where the bones in the vertebral bodies aren't stacking up quite right. There's a little bit of slippage, and that's very important too for rating consideration. And then, of course, the case has to be apportioned. So we're looking for pathology that can be contributing to their permanent disability, arthritis, instability, things of these nature. And so, again, as you're training yourself and reading these reports, you want to get a flavor from top to bottom. And when you get through and you're at the bottom of that report, you want to already be prepared and know, I think this is the case with some moderate impact. The patients had a fair amount of their ADLs limited. There's some objective pathology on the physical exam. There's loss of motion. There's arthritic changes. There's stability issues on the imaging, et cetera, et cetera. And by putting those things in your mind as you move through, by the time you become familiar with the tables and you're understanding kind of how these things play in, the case is going to make a lot more sense to you. And there's not going to be much question as to the value that's delivered at the end of the report. I will say this, the only place where I see a lot of people, even people of fair amount of experience in impairment ratings, I see this in QMEs all the time, is they don't always make a clean connection to the ADL loss and the whole person impairment. So I just will take a few moments here to talk about that, because that is something that is unobvious in the impairment rating and causes all kinds of problems with inaccuracies, which lead to delays, litigation, etc. So when an individual has an activity of daily living loss, that means by definition, according to the AMA guides on page 5, that they cannot be given a 0% whole person impairment. So like when I'm looking at impairment reports, if I see that that rating has been provided as a 0, the first place I'm looking as what's their work status, do they have lifting restrictions, et cetera, and then I go up to that history. I expect to see some pain scores. I expect to see some ADL functions. And if I see a 0, I'm not expecting to see any description of limitations on standing, walking, sitting, etc. If I do, I know that there's a problem. And the reason I point this out is you will come up with your own method as you look through impairment reports. And again, today's topic is big themes in impairment ratings. So based on the value you see, you have to walk it back, connect it to the history, connect it to the diagnostic tests. And if all of those things are not lining up, we either have an incomplete history, we have an inaccurate history, or we're missing diagnostic tests, or the impairment rating is wrong. And any of those things can contribute to problems. So keep that in mind. I hope this is helpful. Think about big themes in the physical exam, history, and diagnostic test next time you review that impairment report. And we'll see you then.